Welcome to The Summary, a podcast from Mary Freebed, where we explore physical medicine and rehabilitation, one topic at a time. Together, we will gain insights, discover innovations, and deep dive into the latest developments in the field.
Welcome back to the Summary Podcast. I'm your host, Dr. Yunna Sinskey, and I'm so excited to introduce my amazing co-host, Dr. Doug Henry. Dr. Henry is triple board certified in PM&R, pediatrics, and pediatric rehab. He's a true expert in the field of pediatric PM&R and has been practicing over 30 years. He's also the director of pediatric rehab here at Mary Freebed, and I guess he's technically my boss too.
I'm paying attention.
Doug, thanks so much for joining the team.
Hey, Yunna, thank you very much. Happy to join you. I'm looking forward to this series, but especially to today's topic. We talked about getting some expert to talk about functional neurologic disorder. Functional neurologic disorder, or FND, it's a somewhat common diagnosis. It's a misunderstood diagnosis. It's not easy to treat. And so we thought we would look to an expert to help us in our own patients, but hopefully to our viewers as well. Yeah, so we're very excited to have Dr. Ginger Polich here to share with her expertise with FND, functional neurologic disorder. She is double boarded in PM&R and in brain injury medicine. She's assistant professor at Harvard Medical School and clinical investigator at the Mass General Research Institute. And Ginger, we're very excited to have you here and hear what you have to say about FND.
Wonderful. My pleasure. And thank you for the invitation.
Let's get rolling.
All right. So, do you go by Ginger or Dr. Polich?
You can call me Ginger. Please. Yeah.
So, Ginger, can you kind of briefly explain what FND is and how that differs from other neurological conditions?
Yeah. So I think you ask, 100 people, you're going to get slightly different answers from everyone. But so FND is functional neurological disorder, previously known as conversion disorder. But in the last many decades, there's been a lot of new neurologic research in the area that's kind of reframed how we think about it. So the word functional is key in many regards. So when we think about most neurologic disorders, there's typically some type of injury or insult or disease process that affects the structure of the nervous system. In functional neurologic disorder, generally speaking, the structure of the nervous system is intact, but it's the function of the nervous system that's abnormal. So the way that the brain sends signals to the body becomes hijacked in a variety of ways. And you can have a number of different symptoms. You can have paralysis, you can have a tremor, you could change the way you speak. You could have a functional presentation that looks like a seizure, but it's not actually electrographic changes. It's a functional seizure. So that's kind of the semantic answer. The kind of like the bigger picture, I think, is that FND is a neuropsychiatric disorder that's really at the boundary of neurology and psychiatry, and it's really about the whole bio-psychosocial picture. And when we get into it, what causes FND? What are the risk factors? How do you treat it? You really have to look at the entire person to kind of get the answer of why, and then look at the entire person kind of in their whole, environmental complex to get into the answer of like, now what and how do we help this person?
Ginger, you mentioned seizures as one condition that FND may mimic. What are some other conditions that, for our physician listeners who maybe don't see FND much or don't see it at all, what are some other ways that FND can mimic other conditions that they may perhaps miss?
So functional seizures are pretty common, but I'd say that's not really a rehab diagnosis. The presentations of FND that are more rehab can, again, affect the motor system, the sensory system. So you might have somebody who comes in and they're paralyzed. They could have a hemiparesis. They could have a paraparesis. But again, it's, if you image everything, there's no stroke, there's no TBI, there's no brain tumor, there's no spinal infarct, et cetera, et cetera. It's really just how, the body is sending signals. So it can look a lot like our patient population that has structural neurologic injury. You can also have a functional tremor. So you can have a tremor that looks like a Parkinsonian tremor. You could have a tremor that looks like an essential tremor. You could have a tremor that looks super bizarre and doesn't look like any tremor you've ever seen. With speech disorders, again, it kind of runs the whole course, you could have somebody who has functional mutism. Somebody could had a functional stutter, have a functional dysarthria, or have a functional something more bizarre like foreign accent syndrome. Again, because we're talking about not these very concrete rudimentary ways the nervous system is affected, but the functioning of the nervous system. The manifestation can look almost like anything because it's like cortical. It's not, subcortical. It's not brainstem. It can look quite odd or bizarre in some cases.
I feel like in the kids that I've seen who have FND, I've noticed a lot of orthostasis, just like kind of some kind of autonomic dysfunction. Do you see that a lot in adults too?
So that is a whole, I'd say, like new frontier of FND. So, I'm a physiatrist. So the people I see generally have some type of physical, or speech or you name it, impairment. But there are a number of comorbidities and kind of associated symptoms. And someone might come in with a functional hemiparesis, but they also complain of fatigue. So when we think about things like the autonomic nervous system, this is a whole area of, is there something abnormal about the autonomic nervous system that could lead to orthostasis or lead to, tachycardia or something of the sort in FND? And I think that's more commonly appreciated, more commonly evaluated, and more commonly identified than it was before. And this gets into like etiology. What is FND? So abnormal functioning of the nervous system. So there seems to be something in the translation between, again, how the body plans a motor program and then executes a motor program that might involve the autonomic nervous system. And if there's something hyperactive or hypoactive, maybe things can look different, but that is fundamentally involvement of the autonomic nervous system. So maybe you'll also have accompanying autonomic nervous system symptoms.
And I treat kids, and I see once in a while we see these kids in clinic, but most of the time they get admitted to acute care, get the big diagnostic workup, and then if they can't walk or whatever, they come over to rehab, the vast majority. Is that similar to adults, or do they more often present in an outpatient setting with less pronounced symptoms?
So I can't quote you on exact numbers. I would say, we see plenty of people who present acutely. We also see plenty of people who present chronically. So I think if you present acutely and it's really dramatic, like you were walking and now you're not walking, usually that's going to necessitate a whole hospitalization and extensive workup. But we also have situations where somebody, again, this gets into, there's so many manifestations of this, but let's give an example. Like, pain and a functional weakness are often related. So somebody comes in and they roll their ankle and they have some ankle pain. This is the outpatient clinic. And then over time, they should be able to move that ankle, but now the ankle's not working. And then the whole leg's not working. And then that's going to necessitate a whole workup. You're going to do an EMG, you're going to do some spinal imaging, et cetera, et cetera. But then if you start ruling out anything structurally wrong, and you start, doing some of the clinical examination that can rule in FND, you might start to suspect FND in this case. But the difference there is it kind of came on slowly as opposed to came on abruptly. But you absolutely see both.
So how do you then diagnose? Like, how do you rule in and rule out FND?
So I would say, kind of like number one, you rule out other things. So in most cases, you need to do a pretty thorough diagnostic workup, and often that takes, neuroimaging of some sort, maybe, EMG, maybe labs, who knows what. But you need to kind of rule out everything else. But then the idea is ruling in FND. So there's a whole, chapters and articles and whatnot devoted to what is the clinical evaluation to rule in FND. So it's a neurologic exam, but it looks like a little bit different than your elementary neurologic exam. And what you're looking for are a few different features. One, generally speaking, you would expect symptoms to be inconsistent. So, if you know how somebody with hemiparesis would present after a stroke, it might look a little bit different in FND. It would be variable. Often, though not always, these symptoms come and go a little bit. So they might be more present one day than the other day, or it might also come and go as a function of what someone's paying attention to. And typically, if they're paying more attention to their symptoms are more pronounced. But that adds to a variability that you can kind of test for in the clinic. Other signs are suggestibility. Sometimes just by planting an idea of something, you can get a symptom to look better or look worse, and that's part of what you're watching for on the physical exam as well. So, what's an example? So, if somebody comes in with, let's say, a functional tremor, and normally you might look for the tremor when somebody's at rest. You might look for the tremor when somebody's in a certain posture, or you might look for the features of the tremor when they're doing an action. That's maybe a very simple way to look at a tremor when you're just doing your very basic neurologic exam. For FND, if there's a tremor and you suspect it might be functional, you're going to look for those other signs that they're inconsistent and they look a little bit different than these other tremors we know about. But then also they're variable. So an example here is, somebody has a tremor, and it typically, if they had a more, structural neurologically based tremor, it would be consistent and it wouldn't come and go based on what you're saying or what you're doing. But in FND, because we try to unmask normal function, when you're examining their tremor, you might have them start to do something with one hand and see if you can basically change what happens in the other hand. Or you might distract them when they're doing, they put their arms out and they're tremoring. You might do a cognitive task, like, can you count backwards, do serial sevens or something. And that's going to basically take their attention off their tremor and onto a challenging cognitive task. And sometimes that can make the tremor look better. There's other things you can do with, like, rhythm and music to see if you can entrain someone's tremor to a certain beat and then change the beat, and it can speed up or slow down. And this is kind of looking for, in some way, the stickiness of the symptoms or the changeability of the symptoms. But like, you have all these different ways of testing for a functional tremor in your mind. And if you have enough of those symptoms and you ruled out everything else, you can start feeling a lot more confident that this is probably functional.
Yeah, one of the things I really like about seeing FND patients is trying to trick them into doing things that they can't do. I remember this kid who couldn't stand up, but was very proud of how much geography he knew. And we were in the classroom, and I'm having him point out, where's this city, where's that city? And, eventually, to point to Greenland, he had to stand up. And sure enough, he stood up because he's more focused on his geography. Maybe that happens more in kids than adults, but it's one of the things that at least makes it interesting. Now, this is a diagnosis, again, in kids that the kids don't want to have, the parents don't want them to have it, even though the prognosis is good. But how do you explain FND to patients in a way that they will accept it and buy into the treatment?
So I work mostly with adults, but I would say, it's similar on the adult side. There's certainly a stigma around this diagnosis. That's not true for everybody, but it's true for many people. So I think, there's a number of things. Like, first of all, the way you respond or act to their symptoms, matters a ton. Like, are you taking this person really seriously, or are you kind of in the back of their mind being like, oh my God, this is FND? So like, your attitude can certainly show. And that might also be part of, this gets into a whole different tangent, but I'll get back to my point. But a part of, like, how did you come to be there? And sometimes it's, somebody develops FND because they've had a repeated, history of maybe their family or someone kind of invalidating their feelings or invalidating their sickness, or being like, eye rolling at them. So there's some type of almost defense or pain or sadness around, bringing something to a professional. If the professional dismisses them, again, that's only going to kind of add to the whole picture. And then you might see FND symptoms worsen because, right, this is, kind of like part of that whole bio-psychosocial model. Okay. So, but your question was, what do you say? So I think your attitude is probably amongst the most important things. And, I think many of us have worked in settings where you can kind of tell or feel what a clinician is kind of saying with the undertones or without, non-verbally. And so I think sincerity matters. And, even if it feels like, a spinal cord injury that structurally damages your ability to walk is more serious and deserving of compassion than, the functional version. even if we hold biases like this, I think it's important to try to just meet the patient where they are, and they are probably really suffering. Even if this, maybe if we get to their cause is a big bio-psychosocial, and the emotional part has a piece of it, like they're probably really suffering because they can't walk, and or they're really suffering and that's what kind of got them there in the first place. So maybe that's like number 1 through 5 is like, kind of try to bring just some patience with this patient population to the table. Beyond that, I think is talking about it like it's serious. This isn't not a stroke. This is FND, right? This really is affecting you right now. And I'll usually say that to say, like, this is a serious condition. Like, many people can get better from it. Some people can get all the way better from it. But if you don't do anything about it, we don't know. You might not get better. So this is this is a significant diagnosis. And then, I think there's a lot of different, again, rhetoric out there about how to explain it. I find FND, I've been doing this for like 10 years and you're like, what's FND? I still find it hard to like explain it, but like, this is a big part of my job. But there's some like cheat sheets where, people use the jargon of, the functioning of the nervous system, versus the structural hardware versus software. Like, your computer hardware is okay. It's just the software that's disrupted. So the brain is having a hard time sending signals through that software to the body. We need to reprogram the software. We reprogram the software doing things like rehabilitation exercises, or sometimes we reprogram the software by kind of looking at the whole mind-body connection and really get involved with psychotherapy. So I think some of those little pearls can be helpful. And I think then again, giving direction or giving hope to a patient, like, you can get better, you just got to do the work. So I think those are some of the main things I put in the package of explaining what. I would also say, some people aren't ready to hear it. And if somebody's really resistant, I might schedule to have them come back again. And if they still want to do a ton more workup and someone else is going to do that workup, great, come meet me when it's done. And it might not be the time as now. Some others, will partially buy into it, but not fully, but maybe they'll do a course of rehab, or maybe they'll even start working with a psychotherapist. And, maybe it takes months and months and months before we can really talk about what FND is. But before that, we're just kind of trying to treat it. So, people are at different places. And if you stick with them, I find most people come around. Other people, if they're really resistant to it, they might fire you. And that's that. You try your best, but people might fire you.
How do you work? You kind of mentioned psychotherapists. How do you collaborate with them, and are they part of your clinic?
I'm really lucky. I work in the clinic that I work in is at the Brigham and Women's Hospital, and it's a whole FND group. So it's run primarily by neuropsychiatry and neurology, and I'm one of the physiatrists. But we also have social workers who all do clinical counseling. So we have people that we meet once a week as a team, and we run cases, and there's a whole psychotherapy protocol that's developed for FND. So I'm pretty well resourced. It's still hard, but I like have it pretty good. So psychotherapists, there's a couple books out there. I think one by Williams, Overcoming Functional Neurologic Symptoms, a 5-factor approach, right? There's a new one for kids. I'm sorry, I can't tell you the name right now, but it's an FND psychotherapy CBT book, right, for kids. At the Brigham, they developed their own psychotherapy protocol. So there's like following all this, but I would say at large, if you look at how many FND psychotherapists out there, there's like really few. So for the most part, when you practice, you're just going to be with a psychotherapist. And I think any psychotherapist that's good can absolutely treat FND. And, maybe you point them to some of the resources on some of the topics that are sometimes addressed with FND psychotherapy, or maybe I work with a lot of community, even though I have this group, it's like hard to get into psychotherapy with a group still. So I work probably 50% of the time with outpatient psychotherapists who are just in private practice. But I will then take the extra step of like, can we talk? Can we collaborate on the phone? And then I explain this is FND. They don't have, a structural cause for their inability to walk. This is a mind body. I don't want you to just provide, please, supportive therapy for being unable to walk. We're trying to like unravel this whole clinical picture and understand. And then, there's a variety of themes that might be important psychodynamically about like control, agency, sense of being cared for, ability to articulate feelings and senses, and describe emotions versus like hold emotions in. So there's a bunch of themes that I think ultimately matter in a course of psychotherapy too.
What kind of frequency do you tend to use in terms of PTOT, psychology, once a week, several times a week? When do you go inpatient?
So I'll do the outpatient answer first. I mean, I think it's like for this, we are strapped by how insurance companies, kind of design the typical PTOT speech packet. So I would say typically, I try to get someone into the appropriate rehab therapy domains, and it's probably like once to twice a week. It's rarely more than that. Psychotherapy, it's usually once a week. In an ideal world, would it be more intensive? I think it would be. And there's some data that's some programs around the country that I've looked at, like, intensive programs of multiple sessions of PT or OT a day or a week, along with multiple sessions of psychotherapy. They might get somebody out of this FND kind of presentation pretty quick. And I think that's different. It's different because if you have a stroke, like you're not going to be able to recover in 1 week, right? Like you'll recover over time and to whatever extent is possible. But with FND, conceivably, if you had a ton of therapy and all the resources, maybe you could recover in some cases relatively quickly. But we're bound by the way that our healthcare model at large practices care, and FND is not an exception. On the inpatient side, on the inpatient side, I would say this, and this is from our experience in Boston, but also at large throughout the nation for adults. It is hard to get somebody from the outpatient setting into inpatient rehab. It almost never happens. And that's for, again, a number of different reasons, mostly what insurance will pay, pre-authorization, systems that don't want to accept this patient population. There's a bunch of different reasons. So for the most part, when we see inpatients in inpatient rehab, they came from an acute presentation at an acute hospital, and it's not like outpatient and then we went inpatient. So that's what we see. And the people who do present acutely to the inpatient hospital, and then go to inpatient rehab or wherever they go, and this is in our anecdotal experience, but this is also in the research, tend to have a much better prognosis because the symptoms haven't been there as long. Duration of symptoms, is one of the most negative prognostic features of FND. So you want to get on it as quickly as you can.
Yeah, can you tell us a little bit more about the prognosis and how you determine that? Because I feel like, especially us, because we see kids and the parents always want to know, like, when will I get better? Like, what will it take? And I have a really hard time answering those questions.
Right. And there's no, right, there's kind of no answer for some of this. So what would I say? I mean, I think for all of us who practice clinically, whether it's, the other diagnoses I treat are like concussion and whatnot, like you kind of get a feeling over time, like, ooh, how is this going to play out? So you kind of have your clinical intuition to some extent. And I'd say it's based on a number of different things. If it's a new presentation, I think there's more reason to be hopeful that it could reverse itself relatively rapidly, but it completely depends on the why. How did you get to be in this place? And, this is where I've been kind of touching around this, but not being as direct, like the bio-psychosocial load, like, what does that mean? So, there's some nice models about this, about like, maybe FND is like an accumulation of risk factors and you hit a tipping point at some point. So let's say you had a bunch of risk factors. You had severe early childhood adversity, and then you had a significant burden of psychiatric disease, and then you had a medical event or you have pain for some other reason, and then you roll your ankle and you develop functional paralysis. But hey, when we look at this, like, there's all these things that have been kind of like hard in your life before we got to this point. Someone else might come in and maybe they had like a kind of a cleaner life history, but then they had a absolutely catastrophic event, whether it's emotional or physical, and they went from being high functioning and doing just great to like severely impaired with FND. So risk factor accumulation matters, risk factor severity matters. And there's, some people are just, again, if you've been in chronic pain forever, and this is kind of related to your chronic pain in some way, it's going to be a whole lot harder because your risk factor can't be reversed. So I think it's getting a history about how kind of like everything's going. And you can't necessarily get that at the first visit. Like a lot of these relationships I have are pretty longitudinal, and I follow them for months or years in some cases. Um, and sometimes after a really long period of time they get better, but we've been kind of working on some of these risk factors over time. So what's the answer to your question? It's just super individualized and personalized, like the same thing. If again, like a rehab diagnosis, somebody comes in, they're acutely have a concussion, how soon are they can get better? Probably in days to weeks. Somebody comes in, they have a whole like 17 other diagnoses, they've their concussion was 6 years ago and they're still really struggling. Like, do you think it's going to get better in weeks? Like, probably not. So I think it's just like that kind of, holding that whole picture.
You co-authored an article, I think just last year, on exercise and activity in FND, as well as some other comorbidities or similar conditions, chronic pain, and a lot of focus on dysautonomia in that article. And can you kind of give the viewers some tips from that article that you think are important on the dysautonomia or this combination with other conditions?
So again, this is like that paper was a little bit some data and also some kind of like theorizing. But we said the autonomic nervous system is a conduit through which some of these kind of cortical brain base can manifest in the body. So we do find it not uncommonly comorbid with FND, and this can be relevant in a number of different ways. So one, for example, someone could be a little bit more in the hyperadrenergic state, but maybe that's also associated with some degree of being wired to be anxious, which is also associated with some traumatic experiences in life. And so maybe there's some degree that you're just your autonomic nervous system is a little bit hyperactive, and it's part of this messiness of the complex that can contribute to FND. And so the idea there is you target the autonomic nervous system through all the ways we can. So one way would be psychotherapy, to learn relaxation and breathing and whatnot. But exercise is another way that we know, and there's some pretty extensive data at this point of how exercise can affect your nervous system, including your autonomic nervous system. So is there something about again, the biology and the psychology of exercise that could be helpful here? So what do I mean by that? So the biology of that, meaning if you gradually become more mobile and exercising more, you're having this cardiovascular response, you're having this cerebral vascular response, there's some BDNF thrown in, and somehow that is positive. But there's also this like psychology of exercise. So if you're fear avoidant in some ways and you're avoiding pushing yourself or exercising in some ways, but then you start to do an exercise program and you push and you kind of see yourself gradually improve, could there be some positive feedback mechanism of pride, agency, capability? Or also, like when you exercise, you push your autonomic nervous system and you might have a heart rate that is going a little bit faster and you're breathing a little bit faster. And maybe that's almost like an exposure therapy. It's like not as scary anymore because you're kind of doing it under your control. And, rather than someone being like, oh, these sensations in my body are just distressing. What is it? There's just like, oh no, this is part of the exercise response and it's getting stronger over time. And that's not a bad thing. I think people can be fearful and confused and afraid of their body symptoms when they don't have a framework for it. And everyone's different there, but we can see that in some cases.
Yeah, I always wondered which one was first. Like, is the chicken or the egg, right? Is the immobility causing the autonomic dysfunction, or is the autonomic dysfunction like resulting in like immobility? It's such a thing you can't really figure out. Is there like any particular exercise you like to recommend for these patients?
I would say no. I think it's just like I just lower that bar as low as it needs to be in order for someone to feel like they could possibly do it. So if that's like we're walking 5 minutes a day, like good for you. So I would say no. The and maybe there's some data that there's like actually something, I don't know that, but I would say like what do? I'd say I just try to make it doable, and small starts are great. Yeah.
So there's really no magic bullet secret sauce. It's psychotherapy, it's activity through whatever physical therapy, or some sort of direction, and gradual improvement. I'm wondering, and I'll just say in advance, I don't have great expectations you're going to have an earth-shattering answer to this, but do you see any breakthroughs, changes in management, anything like that coming down the road in FND?
I would say, well, I will say a couple things. Like, I think there's been a lot more research. So there's been a lot of research into the nervous system functioning and functional neuroimaging, and that's kind of telling us like what brain patterns are associated with this in terms of like the emotion connections to the motor system and whatnot. But there's a whole nother kind of area that's looking at like biological markers, like is inflammation associated with FND? Are genes associated with FND? Are these things are like pretty biological and not, not quite in the same way this bio-psychosocial model. So I think those are areas that are pretty active in research, and again, this is on the borderline between neurology and psychiatry. It's not just psychiatric, right? But it's also not just neurologic. So it would make sense if beyond all these psychosocial risk factors, there also are some like pretty purely biological risk factors. So that doesn't answer treatment, but that kind of is at least a new area of investigation. In terms of treatment, I think that, it's only been maybe 10 plus years where there's been like the consensus guidelines for PTOT and speech. And when those came out over the last decade, that was pretty, I think, huge, because it was the first time like some of these actual therapeutic approaches from the rehabilitation model were like described and disseminated. And now like they're, you can look at the JNNP, and then they have the again consensus guidelines for PT, OT, and speech, and you can kind of at least have a guide to start. So I think that was important, but that's like pretty low hanging fruit just to have some like PT, OT, and speech techniques, not to undervalue that at all. I think it's a big deal, but also it's not, compared to other neurologic diseases, this is new in terms of even knowing how to treat it. I mean, people are looking at same things that they're looking in other things like, brain stimulation, psychedelics, those kind of things, I think, that are at large in psychiatry, and to some degree in some neurologic diagnoses are being looked at for FND. But I don't think there's any, I mean, how can there be a silver bullet when it's like all of life is part of the answer of how you got here, right? And just like maybe who you are or how you respond to things or how your temperament or your nervous system and all these things, it's just I would be surprised. I don't know if there's like some anti-inflammatory BDNF pill, someday that like fixes this, but maybe.
Yeah, I wonder if there's any study in like twins, right, or siblings, and see how I don't think I've ever seen a twin or a sibling have FND. Have you?
I don't think so, no. Well, this has been fascinating, very helpful for me to get your perspective on the adult side, and some of the articles that you've published, to look through those and get some other insights too. I never really think much about the dysautonomia, but I think that's an interesting thing to look at as well. Any parting comments or any last questions that you have?
No, Ginger, thank you so much for coming on to our show. We really, really, really appreciate your insight.
Yeah, thank you so much.
Pleasure.
Appreciate it.
Okay. Absolutely. Okay. Best of all. Best of all.
Wow, that was such an interesting topic that we talked about today. I've definitely learned a lot. So, Doug, what do you think are the top 3 things that you would take home today?
I think the first thing would be diagnosing FND, or functional neurologic disorder. It's not easy. It's mostly a diagnosis of exclusion. You have to rule out some other neurologic causes to get to the point where you feel comfortable diagnosing FND. And then once you do that, you have to explain that to the patient or the family. And so my second point is, and I think she emphasized this very well, that you need to treat that patient, that set of parents and patient, with respect, respect that diagnosis, Don't make them feel like you're making fun of them, but like we see sometimes that this is a serious diagnosis. It's the real diagnosis. It's disabling, and there is help for that problem. And I think the last thing would be treatment. There's no magic bullet pill for this. It's a lot of hard work. Just like recovery from a stroke, you need lots of physical therapy, OT, or exercise activity, along with psychology and looking at all of the environmental and psychological factors that may have contributed to this problem coming up in the first place.
You've been listening to The Summary, a podcast from Mary Free Bed. I'm your host, Dr. Yunna Sinskey.
And I'm Dr. Doug Henry.
And we want to hear from you.
How are you treating your FND patients in your practice?
Let us know on the comments or on social media.